Hey, the eccentric beings, welcome back. So today is going to be topic of discussion is going to be about trachs. I'm going to briefly kind of just touch the surface of what trachs is and some of the key things that you as the nurse should be looking out for it. And if you are a CNA, things that you can be relating to the nurse because you have the knowledge to know. So a tracheostomy is pretty much a cannula or this type of tube that goes into the trach, usually here, and it provides a way of airway into the lungs. Trachs can be permanent or they can be temporary. I've seen trachs in patients who are pediatrics, your kids, and then I also seen in adults. And a lot of times these children have trachs because they have some type of birth kind of defect, and sometimes their body structure is not normal structure as someone who has a normal body structure. Maybe their body is shaped a little different, so it causes their airway to be a little bit off. So with tracheostomies, usually people with trach, usually but not all the time, they may have CPAP or BiPAP at night. So the purpose of CPAP and BiPAP, usually it's for people who have like COPD, people who have obstructive sleep apnea, and what it's doing is it's releasing excess CO2 from the body. You see, the whole functioning of ventilation is your alveoli, which are these like sacs in your lungs at the bottom of your lungs, help to promote gas exchange. And with gas exchange, your body is releasing the CO2 and bringing in O2. And so I made a video before about if you have too much CO2 in the body, what the causes and effects of it can cause. And one of the big things is excessive tiredness. You feel very tired. Is a key sign, especially if someone who's been on long-term oxygen, or they have some type of respiratory issue, is excessive sleepiness, and they complain of a headache. And so these are things to watch out for that you can keep in mind, especially people who have been on oxygen. So with your tracheostomies, if they are connected to trachs, before I say that, I do want to say too, if you're questioning whether or not your patient or patients who have trachs and vents can eat and drink, some of them can, yes. So if they have the trach and they're not connected to the vent, some of them can actually eat and drink just like anybody else, right? They have no problems eating and drinking. That's no issue. But sometimes they can't, okay? But I want you guys to realize and recognize the signs of low pressure vent alarms versus the high pressure vent alarms. So how I remember low pressure ventilation alarms is the L in low equals leak. So L-E-A-K. So they're either a low pressure alarm, there's a leak somewhere going on in the cuff, maybe it's in the cuff, because some tracheostomies cannulas have cuffs on the end, so maybe there's a leak in the cuff, or there's some type of disconnection. Maybe if the patient is on the ventilator some kind of way, the tube popped off the trach and now there's a disconnection there. So remember, low pressure alarms, L equals leak or disconnect. High pressure alarms, you want to think about secretions, right? So I'm gonna be looking down because I have my notes, but you want to think about secretions. You want to think about even kinks in the tube. So with secretions, you want to think about suctioning, right? One of the big things is making sure that you're suctioning out any mucus that's in the lungs. So when you suction, or before you even suction, you want to make sure that you oxygenate the patient beforehand. That way they're able to breathe, because sometimes when you suction it, they have trouble breathing, right? So you want to make sure you suction before you do this. And you want to also make sure that you use the normal saline bullet. So if you guys ever had like a dual nerve treatment, or if you had asthma before, usually children with asthma, they have like these dual-neb treatments, these breathing treatments. It comes with this breathing machine. Some of them have like the mask, some of them have the mouthpiece, and it's pretty much aerosol going into the lungs to kind of help the lungs to open up. And so typically these treatments do last around 10-15 minutes, but pretty much a normal saline bullet is the same in the same packaging as the dual-neb treatments are. So before you suction, you want to oxygenate. You want to place a couple drops of the normal saline bullet into the trachea. A big tip here is to never suction more than 10 seconds. So when you're suctioning, you always want to suction out. So there's usually like a little thing you can hold on and suction. You want to suction coming out. When you push down, it actually pulls or causes the suction. When you release, it stops the suction. So you want to suction coming out of the trach. You never want to suction going in. When you suction, you want to be rotating the trach in a circular motion, kind of help get any mucus that may be sticking to the sides of the walls out as well. Some key things I want to say before any of this, before any alarm ever goes off, or once the alarm goes off, your first thing is to assess the patient first. Assess, is there any kind of change in the patient's functional status? Because the reason the alarm is going off is probably due to something that the patient is going through. Maybe it's the secretions, maybe their tube popped off. So you want to make sure you assess the patient first, especially if you're listening or hearing like noisy respirations. Assess them first. Never, ever, ever silence any alarms at all. Never silence any alarms. So with trach changes, you want to make sure that you understand how to suction and how to do trach changes. So with trach changes, typically it requires 2 providers. So if you're thinking about working in an inpatient facility like hospitals and you're a bedside nurse, usually you have the respiratory therapist and the nurse or the provider at bedside. That's just a given, right? So with trach changes in the hospital, you're going to have 2 people to do a routine trach change. It's usually a nurse and a respiratory therapist, 2 nurses, 2 respiratory therapists, or maybe a respiratory therapist and a provider, or the nurse and the provider. If you are outpatient and you work maybe like in a home health setting, then you still want to apply the same concepts. But the difference is usually in the outpatient or home health settings, you have the family there and then you will have the nurse. So in this instance, some families prefer them doing it themselves. So some families will actually do the trach change because they just feel more comfortable doing it, and that's their child, and that's totally we totally understand that. But sometimes too, it requires a nurse and a family member to do the trach change. The only instance where you would not need 2 people to do the trach change if it's an emergency trach change. So routine trach changes require 2 people, 2 professional people, we suggest, but if it's outpatient, it'd be the family and the healthcare provider. But if it's an emergency, it does not require, in the outpatient setting, 2 people. And when we talk about emergency trach changes, we're talking about like a mucus plug. So if you ever had pneumonia, if you ever had any type of bronchitis, you understand, how mucus sits in your lungs and it sticks, right? And it feels like you can cough. You're coughing, but it's not coming up. It's like it's sitting there. And some people will complain of right pleural chest pain. So you take your right chest up here, you have pain, and up here, you may have difficult breathing in your lungs. Your oxygen sats may be dropping. These are signs that the mucus may be building up or you're having difficult breathing. And so you also want to realize too that not all patients who have trachs are on ventilation or on vents. Some patients just have the trachs, but they're not on vents. So with this, there's a risk for ventilator-associated pneumonia. So ventilator-associated pneumonia is pretty much pneumonia, right? So pneumonia, you see mucus in the lungs, you see decreased oxygen, difficult breathing, the right pleuritic upper chest pain, the increased need for oxygen, difficult breathing, all these things that go along with pneumonia. You see that, but these patients get it because they're on ventilators. Now, not everyone on a ventilator will get pneumonia. Some people are not on ventilators and they get pneumonia. You know, you have like walking pneumonia, you have all types of pneumonias, but these are specifically associated with people on vents. So in this instance, people who are on ventilation, it's so important that you have oral mouth care, daily oral mouth care with these patients, because bacteria can sit into the mouth, right? Bacteria sits into the mouth, it grows, and it causes it can cause types of illnesses and affect other parts of the body. And so that's why oral care is so important, because with good oral care, it actually prevents any type of infection, especially pneumonia. And not saying pneumonia is hard to treat, but pneumonia is something that can be prevented, you know. So with the trait changes, with pneumonia, I said the signs and symptoms, you know, green, yellow, or red tinge mucus. Sometimes pneumonia can come, you know, very thick mucus in the chest, right pleuritic chest pain, decreased oxygen, increased need for oxygen, decreased oxygen saturation. So usually a normal oxygen saturation on a person who is on room air, which means they don't require any type of oxygen, will be 95% or greater. 95% or greater. People who are requiring oxygen, typically we start seeing them in the 90s. So 90s is normal for patients who have COPD. That's a normal oxygen rate. And so we don't want to overload them with oxygen. Typically patients with COPD, they're going to be on 2 liters at home anyways. So we don't want to overload them with oxygen. But patients who don't typically require oxygen at all, this is concerning. Okay, so you as a nurse, depending on where you work, whether you work in a hospital or inpatient facility, or you work outpatient, whether like home health, you want to make sure that you always have the emergency equipment at bedside. Typically, if you work inpatient, your respiratory therapist is going to set up the room for, and I don't care if the patient has oxygen or not, typically, or a trach, usually this is at bedside. It's just a precaution type thing. So at bedside, you need to be verifying that there is an ambu bag and there is emergency equipment, okay? Same steps would apply. So in home health, you know, you want to make sure, and in the hospital, if you have a patient who has a tracheal vent, you want to always make sure that you're verifying the patient's trach size to the patient's actual trach order. Because sometimes, you know, the patient may go to the provider and the provider may say, okay, I got a new order for the trach size, so they're no longer on this trach. So if that happens and the family tells you, you need to be reaching out, you need to either see the physical order on hand or be reaching out to the provider's office to see what the new order is. You can't always go by what the family says, because just because the provider told the family, he did not tell you as a nurse. So you as yourself have to be diligent and find out what the order is and try to find ways to get the new order in place. And that may be even reaching out to your clinical nurse manager to get this rolling. So at the beginning of your shift, always at the beginning of the shift, if you have a patient who has a trach or a vent, make sure you verify the trach size to the trach, the order of the provider. So if the patient has a 2.5 trach, you want to make sure that the order says 2.5. And you also want to verify the trach size and the trach name. Make sure they align together. Another thing you want to make sure you verify is make sure that you have the ambu bag and make sure that you have the emergency equipment at bedside. So the emergency kit would involve, you know, the patient's trach, normal trach size. So if they have a 2.5, you want to make sure that that is in the kit. And you also want to make sure that the patient has a downsized trach, okay? And all the other equipment that goes into the bag. So with these bags, equipment bags, you want to make sure that you know where the extra equipment is if you need to refill it, because you cannot just depend on, yes, it is a responsibility of each nurse who comes onto the shift to verify the trach size and kit. Does it always get done? No. Does it need to get done? Yes. Because you have to have this at bedside. You don't have time to run and find the equipment. It has to be at the bedside. Time is of the essence here. So like I said, know where the extra supplies is and verify that all your supplies is needed. And sometimes, depending on where you work, I know in some outpatient settings, there's usually a trach kit checklist, and it tells you specifically what you need. You know, you need the trach size, you need the regular trach, you need the downsized trach, you need gloves, you need lubrication, you need this, that, and the fourth. So it lists and gives you a checklist that you can check off daily to make sure that all the supplies is needed. If you notice that you are out of supplies for any reason, you need to be reaching out to your clinical nurse manager to find out how you can go get more supplies, or reach out to the family because they would know as well if you were outpatient. Another thing you need to have at the bedside is oxygen tanks and concentrators. So with oxygen tanks, you need to be making sure that you verify that the oxygen tank and the concentrator actually works. And you need to know what the PSI level of the oxygen tank is. So actually turning on the oxygen tank, making sure that you actually hear that it works. Turning on the concentrator to make sure that you hear that it works. One of the main differences between the oxygen tanks and the concentrators is the oxygen tanks is more portable. It is portable. You can move it, I wouldn't say easily, but it's a little bit more accessible to move. It's not lightweight at all. But the concentrator is a little bit more heavier, it's bulkier, it's very loud. Usually patients are going to use their concentrator first before they use the O2 tanks, because the O2 tanks are going to be more of, the patient has to go home, they can have it too, have the oxygen tank, and they're not using it, constantly. Whereas versus them being at home, they can use the concentrator as a continuous type thing. Usually there's going to be certain equipment companies like maybe like DME equipment companies that if there is an issue with the oxygen tank or the concentrator, they can come and replace those equipment. But that's why I'm saying you have to make sure that you verify that the equipment is not working before your shift or during, beginning of your shift. So that way you will know, okay, this stuff ain't working. I can be getting the ball running and get this stuff in order to get some new equipment in place. And I also want to say too, it's so important that you verify that the oxygen is full or not full, right? Or partial full, because you can use a partial full tank, but you can't use an empty tank of oxygen. So if you didn't verify that the oxygen tank was full or partially full before your shift, and then you realize when you really needed it, it was empty, then you're in a mess. And that's just say you don't have a concentrator. So what are you going to do? And this patient requires oxygen. Please make sure that you make sure you're looking at the oxygen tank and you're looking at the number for PSI, looking at, okay, is it in the full range? Is it in the partial range? Or if it's in the empty range? If it's empty, once again, you need to be reaching out to the equipment company, the DME company, equipment company, to see if they can bring you in a new oxygen tank. Okay. But yeah, with the trachs and vents, it's just so important that you understand the alarms, why the alarms is going off. You understand about the patient. It's so important too that you know these types of things, because I want to say too, as a nurse who has experience with trachs and vents, you are a commodity in the nursing field. If you have experience with trachs and vents, you are a commodity in the nursing field, because there's not too many nurses who have this experience. The thing about it is, a lot of your ICU nurses, a lot of your step-down nurses, they have the vent and trach experience. And especially if you want to go into home health, you really need to have this type of experience. And I'm not even saying that you have to go into ICU or a step-down unit to have trach and vent experience, because home health will teach you about trach and vent experience. But it's highly suggested that you continue to learn, continue to study, continue to ask questions, to continue to be around, especially respiratory therapists, even ask the families, because the families, they know a lot about it because their family members or their child has been using it since they were a baby. And so they had to learn throughout the years. And so they know about it. They know about the ventilation. They know about low pressure alarms. They know about the settings. I do want to add that too. I'm glad I thank you, guys. The settings on the alarm. So the settings on the alarm placed by the orders is going to be also placed by the provider. You as a nurse, you should never, ever, ever change settings on any type of ventilations or vent alarms. This is only done by the provider and respiratory therapist. Provider, respiratory therapist. Provider, respiratory therapist. Provider, respiratory therapist. If a nurse tells you it's okay for you to change the settings on the order, you tell them no, because that is out of your scope of practice to change any settings on a vent alarm. I don't care if you were in or outpatient. That is out of your scope of practice, and you have to know that you cannot do that. Okay? So don't go in there changing the settings on the alarm. Now, you can write down the settings to give to the next nurse, but you cannot change it. You cannot change it. And even then, the family should not be changing it either. The alarm settings, they think, that's my child, can change the settings. But it's also so important that you understand that they shouldn't be doing it either. But you as a nurse, you especially should not be doing it. If they are doing it, you need to be reaching out to your clinical nurse manager or your charge nurse, someone in that nature, because, it's set for a certain reason. So yeah, you guys, those were my main topics. I'm going to just recap briefly about what we just discussed. So with vent trach patients, you always want to assess the patient first. You never want to silence any of the alarms. 3, you want to know about your low pressure alarms. Low pressure and L equals a leak or a disconnect. Your high pressure alarm is going to equal, if there's some type of secretions or there's some type of kink in the alarm. Remember, with your secretions in the lungs, you want to remember no suctioning. Don't suction more than 10 seconds. But when you do suction, you always suction out, never in. And you want to suction in a twisting motion. Before you suction, you do want to oxygenate, give oxygen. And then you want to place a couple of drops of normal saline bullet in if you have an order for it, okay? You want to watch out for ventilator-associated pneumonia, such as the green, yellow, or red tinged mucus. If you have a routine trach change, you want to make sure that usually trach changes are I believe it's every 3 days. I believe it's every 3 days because it changes so much, or every week or so like that. Some patients used to do it every week, but with the routine trach changes, it has to be more frequently. I know I'm thinking about PEG tubes, they're changed every 3 months, but the trach changes, I believe if it hadn't changed, it's still every 3 days. But yeah, but the routine trach changes, you want to make sure that you have two people, doing the change. So 2 nurses, 2 respiratory therapists, a nurse and a respiratory therapist and a provider, or a nurse and a provider. If it is an emergency trach change, you do not require 2 people to do this. You can even use a family member and a nurse if you are outpatient. You also, at the beginning of your shift, want to verify at the bedside the emergency equipment. Always make sure you have an ambu bag. In the equipment, you want to make sure that you have the proper trach size. You verifying the trach size to the provider's order. In the kit, you want to make sure that you have we'll say 2.5. You want to make sure that that's in the kit. Also, the downsized trach. And a tip that was taught to me is when you use these trachs, you want to use a sterile catheter, suction catheter to thread through the trach to kind of help it align into the trachea. So that's a good tip too. And you can also use a sterile catheter tip to replace a NG tube. So let's say the NG tube popped out. You want to place the catheter in place in that positions to hold it in place. The same goes with the trach. If the trach accidentally pops out, you can go ahead and automatically put a sterile catheter in place to hold the opening, because if there's a newer trach, which is less than 7 days, it can close very quickly. If it's an older trach, greater than 7 days, it don't close as quickly, but the hole can close back up. So you're putting the trach, the catheter, into the hole to keep the opening. I just want to add it in there. So I said verify the bag, make sure you got your supplies, make sure you know what extra supplies is, make sure you know the number for your equipment company. Like if it's a DME equipment company, they need to come and replace the oxygen tank. They need to replace the concentrator. You need, extra supplies in any area. You need to make sure that you're calling these people to get the supplies that you need. Like I said, some families are very good at this. But once again, you are there to help the families. If you work outpatient, you are there to help. So sometimes the families won't call. The nurses have to do it. So know your numbers for your equipment companies in case you do need extra supplies. So I pray this helps you guys. And I will catch you guys in the next episode.